Heart failure. Heart failure is a complex clinical syndrome that results in the inability of the heart to provide sufficient blood to meet the oxygen needs of tissues and organs. It is a major health problem in the United States. A defect in either the ventricular filling, the diastolic dysfunction, or the ventricular ejection, the systolic dysfunction, are the key manifestations of heart failure. The amount of blood pumped by the left ventricle with each heartbeat is called ejection fraction. The ACCF has adopted the terms heart failure with reduced EF and heart failure with preserved EF to describe systolic and diastolic heart failure. Heart failure is associated with numerous types of cardiovascular diseases, particularly long-standing hypertension, coronary artery disease, and myocardial infarction. In contrast to other cardiovascular diseases, heart failure is increasing in incidence and prevalence. This is due in part to better survival after cardiac events in the aging population. Heart failure is primarily a disease of older adults. The incidence is similar in men and women. The AHA estimates that over 650,000 new cases are diagnosed each year. Heart failure is the most common reason for hospital admission in adults over the age of 65, and this places a significant economic burden on the healthcare system. The complex, progressive nature of heart failure often results in poor outcomes, the most costly being hospital readmissions. Approximately 25% of patients discharged with a primary diagnosis of heart failure are readmitted within 30 days. The total cost of heart failure care in the United States exceeds $40 billion annually, with over half of these costs spent on hospitalizations. Hypertension and CAD are the primary risk factors for heart failure. Hypertension is a modifiable risk factor that should be aggressively treated and managed. Long-term treatment of hypertension reduces the incidence of heart failure by 50%. Other comorbidities such as diabetes, metabolic syndrome, advanced age, tobacco use, and vascular disease also contribute to the development of heart failure. Heart failure may be caused by any interference with normal mechanisms regulating cardiac output. So cardiac output depends on preload, afterload, myocardial contractility, and heart rate. Any changes in any of these factors can lead to decreased ventricular function in heart failure. The major causes of heart failure can be divided into two groups. We have primary and precipitating. Primary causes include hypertension, coronary artery disease, rheumatic heart disease, congenital heart defects, pulmonary hypertension, cardiomyopathy, hyperthyroidism, valvular disorders, and myocarditis. Precipitating causes include anemia, infection, hypothyroidism, dysrhythmias, bacterial endocarditis, obstructive sleep apnea, pulmonary embolism, nutritional deficiencies, and hypervolemia. The most common form of heart failure is left-sided. Left-sided heart failure results either from the inability of the left ventricle to empty adequately during systole or fill adequately during diastole. Left-sided heart failure can be classified either systolic, diastolic, or mixed systolic and diastolic failure. Left-sided heart failure results from left ventricular dysfunction. This prevents normal forward blood flow and causes blood to back up into the left atrium and pulmonary veins. The increased pulmonary pressure causes fluid leakage from the pulmonary capillary bed into the lungs. This manifests as the pulmonary congestion and edema. Systolic failure results from the inability of the heart to pump blood effectively. The hallmark of systolic failure is a decrease in ejection fraction. Normal ejection fraction is 55% to 60%. Patients with systolic failure usually have less than 45%. It can be as low as 5 to 10. Systolic failure is caused by impaired contractile function, increased afterload, cardiomyopathy, and mechanical abnormalities. So increased afterload would be hypertension, and some mechanical abnormalities would be valvular heart disease. The left ventricle in systolic failure loses its ability to generate enough pressure to eject blood forward through the aorta. Over time, it becomes dilated and stretched out. The weakened heart muscle then cannot generate an adequate stroke volume, which then affects the cardiac output. When the left ventricle fails, blood backs up into the left atrium, and this causes the fluid accumulation in the lungs. Diastolic failure. So this is the inability of the ventricles to relax and fill during diastole. Approximately 50% of patients have diastolic failure. Hypertension is the most common cause. Other risk factors include old age, female gender, diabetes, and obesity. In diastolic failure, the left ventricle is generally stiff and non-compliant. Diastolic failure is characterized by high filling pressures because of stiff ventricles. Decreased filling of the ventricles results in decreased stroke volume and decreased cardiac output. And the end result of diastolic failure is the same as systolic, the pulmonary congestion. Mixed systolic and diastolic failure is seen in disease states such as dilated cardiomyopathy. DCM is a condition in which poor systolic function is further compromised by a dilated left ventricle wall that is unable to relax. These patients often have extremely low ejection fractions, less than 35%, high pulmonary pressures, and biventricular failure. So both ventricles are dilated and have poor filling and emptying capacity. Right-sided heart failure occurs when the right ventricle fails to pump effectively. When the right ventricle fails, fluid backs up into the venous system. This causes movement of fluid into the tissues and organs, so peripheral edema, abdominal ascites, hepatomegaly, and jugular venous distension. The most common causes of right-sided heart failure is left-sided heart failure. As the left ventricle fails, fluid backs up into the pulmonary system, causing increased pressure in the lungs. The right ventricle has to work harder to push blood into the pulmonary system. Over time, this increased workload weakens the right ventricle and gradually it fails. Other causes of right-sided heart failure include right ventricular infarction, pulmonary embolism, and cor pulmonale. That's a right ventricular dilation and hypertrophy caused by pulmonary disease. The patient with ventricular failure of any type may have low blood pressure, low cardiac output, and poor renal perfusion. Heart failure can have an abrupt onset, as with acute MI, or it can be a subtle process resulting from slow progressive changes. The overloaded heart uses compensating mechanisms to try to maintain adequate cardiac output. The main compensation mechanism includes hormonal responses, renin-angiotensin-aldosterone system, and the sympathetic nervous system. Also includes ventricular dilation, and finally ventricular hypertrophy. The RAS is a regulatory system that works to maintain normal homeostasis. The activation of the RAS results in BP control and fluid and electrolyte balance. In response to stress, the role of the RAS is to promote retention of fluid and sodium and cause vasoconstriction to raise the BP. However, recurrent activation of the RAS in heart failure is what is responsible for the signs and symptoms that develop. The outcome of the cascade results in further water and sodium retention in the already overloaded state and increased workload of the failing heart. Other factors also contribute to the development of HF. The production of endothelin, which is a potent vasoconstrictor produced by the vascular endothelial cells, is stimulated by the ADH, angiotensin II, and catecholamines. This results in further atrial vasoconstriction and an increase in cardiac contractility and hypertrophy. Locally, pro-inflammatory cytokines are released by the heart in response to various forms of cardiac injury, for example, an MI. Two cytokines, tumor necrosis factor and interleukin-1, further depress heart function by causing hypertrophy, contractile dysfunction, and cell death. Over time, a systemic inflammatory response also occurs. In response to an inadequate stroke volume and cardiac output, the SNS is activated, resulting in the response of the catecholamines, epinephrine and norepinephrine. The circulating catecholamines enhance peripheral vasoconstriction and cause an increase in the heart rate and myocardial contractility. Initially, the compensating mechanisms are beneficial with a result of increased cardiac output. However, over time, these factors become harmful and counterproductive as they increase the workload, preload volume, and oxygen requirement in an already failing heart. In heart failure, continuous activation of the neurohormonal responses, so the RAS and the SNS, lead to an elevated levels of norepinephrine, angiotensin II, aldosterone, ADH, and pro-inflammatory cytokines. Together, these factors result in an increase in the heart's workload, ventricular dysfunction, and ventricular remodeling. Remodeling involves hypertrophy of the ventricular myocytes. This results in large, abnormally shaped contractile cells. This altered shape of the ventricles eventually leads to increased ventricular mass, increased wall tension, increased oxygen consumption, and impaired contractility. Although the ventricles become larger, they become less effective pumps. Ventricular remodeling is a risk factor for life-threatening dysrhythmias and sudden cardiac death. Drug therapies to prevent or reverse remodeling and decrease mortality are recommended. These include ACE inhibitors, beta blockers, and aldosterone antagonists. Dilation is an enlargement of the chambers of the heart. It occurs when pressure in the heart chambers, usually the left ventricle, is elevated over time. The muscle fibers of the heart stretch in response to the volume of the blood in the heart. The degree of the stretch is directly related to the force of the contraction. That's what's called the Frank-Starling law. This increased contraction initially leads to increased cardiac output and maintenance of blood pressures and perfusion. Dilation starts as an adaptive mechanism to cope with increasing blood volume. Eventually, this mechanism becomes inadequate because the elastic elements of the muscle fibers are overstretched and can no longer contract effectively, thereby decreasing the cardiac output. Note the enlarged chambers with cardiac dilation. Hypertrophy is an increase in the muscle mass and cardiac wall thickness in response to overwork and strain. It occurs slowly because it takes time for the increased muscle tissue to develop. Initially, the increased contractile power of the muscle fibers leads to an increase in cardiac output and maintenance of tissue perfusion, but over time, the hypertrophic heart muscle has poor contractility, requires more oxygen to perform work, has poor coronary artery circulation, so the tissues become more easily ischemic, and is prone to dysrhythmias. Note the thickened ventricular walls with the hypertrophy. Compare and contrast the dilation and the hypertrophy. Dilation refers to size of filling space. Hypertrophy refers to the thickness of the wall. Thickness of the muscle. The body's ability to try and maintain balance is demonstrated by several counterregulatory processes. So you have your peptides, which are hormones produced by the heart muscle. The ANP is released from the atria, and the BNP is released from the ventricles in response to increased blood volume in the heart. And the peptides have renal, cardiovascular, and hormonal effects. Renal effects include increased filtration rate and diuresis, and also excretion of sodium. Cardiovascular effects include vasodilation and decreased BP. Hormonal effects include the inhibition of aldosterone and renin secretion, and it also interferes with ADH release. The combined effects of ANP and BNP help to counter the adverse effects of the SNS and the RAS in the patient with HF. Oxide and prostaglandin are counter-regulatory substances released from the ventricular endothelium in response to the compensating mechanism activated in heart failure. So, like the peptides, nitric oxide and prostaglandin work to relax the arterial smooth muscle, resulting in vasodilation and decreased afterload. Compensated heart failure occurs when the compensating mechanisms succeed in maintaining an adequate cardiac output that is needed for tissue perfusion. Decompensated heart failure occurs when these mechanisms can no longer maintain adequate cardiac output and inadequate tissue perfusion results. Heart Association developed functional guidelines for classifying people with heart disease based on tolerance to physical activity. You can see this in your book on table 34-3. Acute decompensated heart failure is defined as the sudden onset of signs and symptoms of heart failure requiring urgent medical care. The universal finding of ADHF is pulmonary and systemic congestion due to elevated left-sided and right-sided filling pressures. In acute decompensated heart failure, ADHF, the pulmonary venous pressure increases caused by failure of the left ventricle. This results in engorgement of the pulmonary vascular system. As a result, the lungs become less compliant and there is an increased resistance in the small airways. To help compensate, the lymphatic system increases its flow to help maintain a constant volume of the pulmonary extravascular fluid. This early stage is clinically associated with mild increase in respiratory rate and decrease in partial pressure of oxygen in the arterial blood. If pulmonary venous pressure continues to decrease, the increase of intravascular pressure causes more fluid to move into the interstitial space than the lymphatics can remove. So interstitial edema will occur at that point. Respiratory rate then becomes higher and the patient becomes symptomatic, so short of breath. If the pulmonary venous pressure increases further, then the lungs are then going to be flooded with fluid. You'll see a worsening of arterial blood gas values and possible partial pressure of carbon dioxide in the arterial blood as well. And respiratory acidosis. ADHF can manifest as pulmonary edema. This is an acute, life-threatening situation in which the lungs have become filled with serosanguine fluid. The most common cause of pulmonary edema is left-sided heart failure, secondary to CAD. As pulmonary edema progresses, it inhibits oxygen and carbon dioxide exchanges at the interface. So in A, figure A, that's a normal relationship. B, increased pulmonary capillary hydrostatic pressure causes fluid to move from the vascular space into the pulmonary interstitial space. Then in C, the lymphatic flow increases in an attempt to pull fluid back into the vascular or lymphatic space. And then in figure D, failure of lymphatic flow and worsening of left heart failure result in the movement of the fluid into the interstitial space and then into the lungs. Clinical manifestations of pulmonary edema are distinct. You need to know these. Patient has difficulty breathing, orthopnea, unable to lie flat due to shortness of breath. Jugular venous distension is often present and is the most sensitive and specific sign for elevated left ventricular filling pressures. The patient is usually anxious, pale, possibly cyanotic. The skin is clammy and cold from vasoconstriction caused by the stimulation of the SNS. Respiratory rate is often greater than 30 beats a minute, and the use of accessory muscles to breathe is evident. There may be wheezing and coughing with the production of frothy, blood-tinged sputum. Breath sounds may reveal crackles and wheezes throughout the lungs. The absence of crackles does not rule out ADHF, as many patients with history of chronic heart failure develop increased lymphatic drainage of the alveolar edema. The patient's heart rate will be rapid and abnormal, so S3 and S4 heart sounds may be auscultated. Blood pressure may be elevated or decreased depending on the severity of the of heart failure. Patients with ADHF can be put into four groups, four different categories, based on hemodynamic and clinical status. So category number 1 is dry warm, 2 is dry cold, 3 is wet warm, which is the most common, and 4 is wet cold. The most common is the wet warm. A patient is wet due to the volume overload, so the congestion and the difficulty breathing, but warm due to adequate perfusion, warm skin, positive pulses. Chronic heart failure is characterized as progressive worsening of ventricular function and chronic neurohormonal activation that result in ventricular remodeling. This process involves changes in the size, shape, and mechanical performance of the ventricle. The clinical manifestations of chronic heart failure depend on the patient's age, underlying type and extent of heart disease, and which ventricle is failing to pump effectively. The Heart Failure Society of America developed the acronym FACES: fatigue, limit of activities, chest congestion or cough, edema, and shortness of breath, to help educate patients of identifying heart failure symptoms. Fatigue is one of the earliest symptoms of chronic heart failure. The patient notes fatigue after usual activities and eventually limits these activities. The fatigue is caused by decreased cardiac output, impaired perfusion to vital organs, decreased oxygenation of the tissues, and anemia. Difficulty breathing, or dyspnea, is the common manifestation of chronic heart failure. It's caused by increased pulmonary pressures secondary to interstitial and alveolar edema. It can occur with mild exertion or at rest. Orthopnea often accompanies this. Careful questioning of patients often reveals adaptive behaviors such as sleeping with 2 or more pillows or in a chair to aid breathing. PND occurs when the patient is asleep. The patient awakes in a panic, has feelings of suffocation, and strong desire to sit up or stand up. PND is caused by the reabsorption of fluid from dependent body areas when the patient is flat. A cough is often associated with heart failure and may be the first clinical symptom. It begins as a dry, non-productive cough and may be misdiagnosed as asthma or another lung disease. The cough is not relieved by position change or over-the-counter cough medicine. Tachycardia is an early clinical sign of heart failure. One of the body's first responses to compensate for a failing heart is to increase the heart rate with the activation of the SNS. This works to increase cardiac output. Initially, this response is favorable, but over time, persistent tachycardia is harmful and may exacerbate heart failure. Adequate heart rate control in patients with chronic heart failure has been associated with better clinical outcomes, including decreased hospitalizations and mortality. Edema is a common sign of heart failure. It may occur in dependent body areas, so peripheral edema, liver, abdominal cavity, and lungs. If the patient is in bed, sacral and scrotal edema may develop. Pressing the edematous skin with a finger may leave a transient depression, which is what we call pitting edema. The development of dependent edema or sudden weight gain of more than 3 pounds in 2 days is often a sign of ADHF. It is important to note that not all lower extremity edema is a result of HF. There are many other causes. Nocturia is the tendency to urinate excessively during the night. Chronic HF is frequently associated with poor renal perfusion and function. Patients develop increased peripheral and systemic edema. At night, when lying flat, extravascular fluid is reabsorbed from the interstitial spaces back to the circulatory system. This results in increased perfusion to the kidneys. The increased renal blood flow results in diuresis. The patient may complain of having to urinate frequently throughout the night. Here's a picture of pitting edema. Note the finger-shaped depressions that do not rapidly refill after the examiner has exerted the pressure. Skin changes. Because tissue capillary oxygen extraction is increased with a person with chronic HF, the skin may appear dusky. Often the lower extremities are shiny and swollen with diminished or absent hair growth. Chronic swelling may result in pigment changes. This causes the skin to appear brown or brawny in areas covering the ankles and lower legs. Behavioral changes. Cerebral circulation may be reduced with chronic HF secondary to decreased cardiac output. The patient or caregiver may report unusual behavior, including restlessness, confusion, and decreased attention span or memory. This may also be secondary to poor gas exchange and worsening heart failure. It is often seen in the late stages of heart failure. Coexisting psychologic disorders, especially depression and anxiety, contribute a twofold risk of mortality and higher readmission rates and healthcare costs in patients with HF. Approximately 1 in 5 patients with heart failure have clinical depression. In addition, patients with psychological disorders have poorer adherence to treatment plans. Chest pain. Heart failure can precipitate chest pain or angina due to decreased coronary artery perfusion from decreased cardiac output and increased myocardial work. Chest pain may accompany either ADHF or chronic HF. Weight changes. Many factors contribute to weight changes. First, there may be a progressive weight gain from fluid retention. Renal failure may also contribute to fluid retention. Abdominal fullness from ascites or the swelling of the liver frequently causes anorexia and nausea. As heart failure advances, the patient may have cardiac cachexia. It's cachexia, with muscle wasting and fat loss. This can be masked by the patient's edematous condition and may not be seen until after the edema subsides. Pleural effusion. So these are complications of heart failure. PEs are a common complication of heart failure. There are 2 pleural layers or membranes. Normally, a small amount of fluid is between the 2 layers for lubrication and to aid breathing. A PE occurs when excess fluid builds up in the pleural cavity of the lungs. Dysrhythmias. Chronic heart failure causes enlargement of the chambers of the heart. The enlargement can cause changes in normal electrical pathways. Patients with heart failure are at risk for ventricular dysrhythmias. So, ventricular tachycardia, ventricular fibrillation. Patients with decreased left ventricular function are at greater risk for SCD. They're also at risk for AFib, and AFib promotes thrombus formation within the atria. So this also places the patient at risk for stroke, since a thrombus might break loose and form an emboli. So oftentimes they may require treatments with anticoagulants, cardioversion, ablation, and antidysrhythmic drugs. With ADHF and chronic HF, the enlarged left ventricle and decreased cardiac output combine to increase the risk of thrombus formation in the left ventricle. Once a thrombus is formed, it may also decrease left ventricular contractility. So then it's going to decrease the cardiac output and worsen the patient's perfusion. And development of an emboli from the thrombus also puts the patient at risk for stroke. Hepatomegalia. Heart failure can lead to severe liver swelling, especially in right ventricular failure. The liver becomes congested with venous blood. The hepatic congestion leads to impaired liver function. Eventually, liver cells die, fibrosis occurs, and cirrhosis can develop. Renal failure. The decreased cardiac output that accompanies chronic heart failure increases a decreased perfusion to the kidneys and can lead to renal insufficiency or failure. Diagnosing heart failure is often difficult. Patient signs and symptoms are not highly specific and may mimic those associated with many other medical conditions. For example, anemia and lung disease. A primary goal in diagnosis is to find the underlying cause of heart failure. An echocardiogram is a common diagnostic tool used in patients with heart failure. It provides information on ejection fraction. This helps to differentiate between what type of failure it is. An echocardiogram also provides information on the structure and function of the heart valves. Heart chamber enlargement or stiffness can also be assessed. Other useful tests include an ECG or an EKG, chest x-ray, 6-minute walk test, multi-gated acquisition scan, cardiopulmonary exercise stress tests, and a heart cath. Studies for obstructive sleep apnea may be done in select patients. An endomyocardial biopsy may be done as part of the heart cath in select acutely ill patients who develop unexplained new onset heart failure that is unresponsive to usual care. Laboratory studies also aid in the diagnosis of heart failure. In general, the BNP levels correlate positively with the degree of left ventricular failure. Many agencies routinely measure the N-terminal prohormone of BNP. This is a more precise test to aid in the diagnosis of heart failure. Levels are temporarily higher in patients receiving Natracor and may be high in patients with chronic, stable heart failure. Increases in BNP or the pro-BNP levels can be caused by conditions other than heart failure. These include pulmonary embolism, renal failure, and acute coronary syndrome. Patients with ADHF need continuous monitoring and assessment. This is done in the ICU if the patient is unstable. In the ICU, monitor the heart rhythm and oxygen saturation continuously. Assess vital signs and urine output at least every hour. The patient may have hemodynamic monitoring, including arterial blood pressure and pulmonary artery pressures. If a pulmonary artery catheter is placed, evaluate cardiac output and pulmonary artery wedge pressure. Therapy is titrated to maximize cardiac output and reduce pulmonary artery pressure. A normal PAWP, so a normal pulmonary artery pressure, is generally between 8 and 12. Patients with ADHF can have as high as 30. So hemodynamic monitoring is discussed more in Chapter 65. Provide supplemental oxygen to help increase the percentage of oxygen inspired. In severe pulmonary edema, the patient may need a non-invasive positive pressure ventilation. So they might need a BiPAP. Or intubation and mechanical ventilation. BiPAP is also effective in decreasing preload. Some patients with ADHF require hospitalization but are more stable. They are often admitted to a telemetry or step-down unit for treatment. Assess these patients every 4 hours, so you got to get the vitals and the pulse ox for adequate oxygenation. Record intake and output on daily weights to evaluate fluid status. If the patient has difficulty breathing, put them in high Fowler's position with the feet horizontal in the bed or dangling at the bedside. This position helps decrease venous return because of the pooling of blood in the extremities. This position also increases the thoracic capacity, allowing for improved breathing. Ultrafiltration, or aquapheresis, is an option for patients with volume overload. It is a process to remove excess salt and water from the patient's blood. UF can rapidly remove extravascular fluid volume while maintaining hemodynamic stability. The ideal patients for UF are those with major pulmonary or systemic volume overload who have shown resistance to diuretics and are hemodynamically stable. UF also may be an appropriate adjunctive therapy for patients with HF and coexisting renal failure. In the ICU, circulatory assist devices are used to manage patients with worsening heart failure. So the intra-aortic balloon pump is a device that decreases coronary blood flow to the heart muscle. It increases coronary blood flow to the heart muscle, and it decreases the heart's workload through a process called counterpulsation. This device is useful in hemodynamically unstable patients because it decreases pulmonary artery pressures and systemic vascular resistance, leading to improved cardiac output. Ventricular assist devices can be used to maintain the pumping action of the heart that cannot effectively pump. It's a mechanical pump that's surgically implanted. Once the patient is more stable, determination of the cause of the ADHF is important. Diagnosis of systolic or diastolic heart failure will then direct further treatment protocols. Here's a left ventricular assist device. So drug therapies. Diuretics we're going to use. They're the mainstay of treatment in patients with fluid volume overload. They act to decrease sodium reabsorption at various sites with the nephrons, thereby enhancing sodium and water loss. Loop diuretics, for example, furosemide, or another name for that is Lasix, can be given IV push and act rapidly in the kidneys. Then we have vasodilators. IV nitroglycerin is a vasodilator that reduces circulating blood volume. It also improves coronary artery blood flow by dilating the coronary arteries. Therefore, nitroglycerin reduces preload, slightly reduces afterload, and increases myocardial oxygen supply. When titrating IV nitroglycerin, monitor BP frequently, every 5 to 10 minutes, to avoid hypotension. Sodium nitroprusside, or nipride, is a potent IV vasodilator that reduces both preload and afterload. It improves myocardial contraction. It increases cardiac output and reduces pulmonary congestion. Complications of this med include hypotension, thiocyanate toxicity, which can develop after 48 hours of use. And this medication is usually given in the ICU, since hypotension is a main adverse reaction. And then you have nicerotide, also given IV, and it is a recombinant form of BNP. It causes both atrial and venous dilation. The main hemodynamic effect of this medication includes a reduction in your PAWP and a decrease in systemic BP. Although classified as a vasodilator, it's also known as a neurohormonal blocking agent. It can be used for short-term treatment of ADHF. It doesn't require titration after the initial IV bolus, and it can be given in an emergency. And once again, because the main adverse reaction to this medication is hypotension, you got to monitor that blood pressure every 5 to 10 minutes if that's a medication that you're giving. Morphine. Morphine reduces preload and afterload, believe it or not. It is frequently used in the treatment of heart failure and acute coronary syndrome. It dilates both pulmonary and systemic blood vessels. When morphine is used, the patient often experiences relief from difficulty breathing and consequently the anxiety often associated with the difficulty of breathing. Use morphine cautiously in patients with ADHF. Morphine is related to more adverse events, including a greater need for mechanical ventilation, more ICU admissions, prolonged hospitalization, and higher mortality rates in these patients. Positive inotropes. Inotropic therapy increases myocardial contractility. We have a number of drugs. We have the B agonists, so dopamine, dobutamine, norepinephrine, or Levophed. We also have phosphodiesterase inhibitors. And then we also have digitalis, or digoxin. Currently, the inotropic therapy is only recommended for use in short-term management of patients with ADHF who've not responded to conventional drug therapy like diuretics, vasodilators, and morphine. So our main treatment goals include, with the addition of new drugs and devices, the management of HF has dramatically changed in the past few years because of the large number of patients and the high cost of care related to hospital readmission. Strategies to improve outcomes have been developed. One example is the use of the guideline-directed medical therapy as defined by the AACF and the AHA. Another example is specialized heart failure inpatient units with transitional programs to the outpatient setting to help manage these patients. These units are staffed with multidisciplinary heart failure teams, including nurses who are educated in the care of these patients. The main goals in treatment of chronic heart failure are to treat the underlying cause and contributing factors, maximize cardiac output, reduce symptoms, improve ventricular function, and improve quality of life, preserve target organ function, and improve mortality and morbidity risks. In a person with heart failure, oxygen saturation of the blood can be reduced because the blood is not adequately oxygenated in the lungs. The use of supplemental oxygen improves saturation and assists in meeting tissue oxygen needs. This helps to relieve difficulty breathing and fatigue. Optimally, either pulse oximetry or ABGs are used to monitor the need for and effectiveness of oxygen therapy. Physical and emotional rest allows the patient to conserve energy and decreases the need for additional oxygen. The degree of rest recommended depends on the severity of heart failure. A patient with severe heart failure may be on bed rest with limited activity. A patient with mild to moderate can be ambulatory with restriction of strenuous activity. The patient should be told to participate in prescribed activities with adequate recovery periods. A structured exercise program, such as cardiac rehabilitation, should be considered for all patients with chronic heart failure. CR has been associated with decreased hospitalizations and reduced mortality. Patients enrolled in cardiac rehab programs have also reported improved quality of life and less depression. The CardioMEMS system is a new device to help monitor patients' pulmonary pressures. It's implanted in the patient's distal pulmonary artery during a right heart cath. The permanent device is approved for patients with NYHA Class 3 heart failure symptoms. It allows for close monitoring of changes in pulmonary pressures. Patients with an ejection fraction less than 35% are at an increased risk of SCD from ventricular tachycardia or fibrillation. An ICD is recommended for SCD prophylaxis. In heart failure, neurohormonal effects of cardiac remodeling can result in desynchrony of the left and right ventricle. This contributes to poor cardiac output. In these patients, biventricular pacing, known as cardiac resynchronization therapy, is recommended. In CRT, an extra pacing lead is placed through the coronary sinus to a coronary vein of the left ventricle. This lead coordinates right and left ventricular contractions. The ability to have normal electrical conduction between right ventricle and left ventricle increases left ventricular function and cardiac output. At times, patients may need both the CRT and an ICD. Several mechanical options are available to sustain heart failure patients with deteriorating conditions, especially those awaiting heart transplantation. These include the IABP and the VADs. However, the limitations of bed rest and the risk of infection and vascular complications preclude long-term use of the IABP. VADs provide highly effective long-term support and have become standard care in many heart transplant centers. The heart pump is operated via a drive line that exits the abdominal wall and is attached to a system controller with the patient-specific settings. VADs operate on an AC current or batteries. This is just placement of the pacing leads and cardiac resynchronization therapy. So more specifically, diuretics are used to reduce edema, pulmonary venous pressure, and preload. So blood volume returning to the heart can be reduced and cardiac function improved. Diuretics act on the kidney by promoting excretion of sodium and water. Many varieties of diuretics are available. We have loop diuretics like Bumex or bumetanide. These drugs act on the ascending loop of Henle to promote sodium chloride and water excretion. Problems in using loop diuretics include reduction of serum potassium levels, ototoxicity, and possible allergic reaction in patients sensitive to sulfa-type drugs. Thiazide diuretics inhibit sodium reabsorption in the distal tube, thus promoting excretion of sodium and water. They can be added to loop diuretics to obtain results if patients become resistant to loop diuretics. Thiazide diuretics can also cause severe reductions in potassium levels. Diuretics are effective in relieving the congestive symptoms of heart failure. However, their use does not activate the SNS or the RAS, which can exacerbate the heart failure syndrome. In chronic heart failure, the lowest effective dose of diuretic should be used. We have the ACE inhibitors, our primary drug of choice for blocking the RAS system in heart failure patients with systolic failure. The conversion of angiotensin 1 to potent vasoconstrictor angiotensin 2 needs ACE. ACE inhibitors block this enzyme, resulting in reduced levels of angiotensin 2. These drugs can cause symptomatic hypotension, intractable cough, hyperkalemia, angioedema, so that's an allergic reaction involving edema of the face and airways, and a renal insufficiency, and that's with high doses of an ACE inhibitor. Angiotensin 2 receptor blockers. For patients who are unable to tolerate ACE inhibitors, angiotensin 2 receptor blockers, or ARBs, that's what we call them, are recommended. These agents prevent the vasoconstriction and aldosterone secreting effects of angiotensin 2. And then you have some examples of those, the ARBs, valsartan, irbesartan. Look at your handout. Aldosterone antagonist, spironolactone or aldactone is one example. They block the harmful neurohormonal effects of aldosterone on the heart blood vessels. They are also potassium sparing that promote sodium and water excretion while retaining the potassium. These effects occur because these agents bind to the receptors at the aldosterone-dependent sodium-potassium exchange site in the distal renal tube. Then you have the beta blockers, and they directly block the negative effects of the SNS on the failing heart. We have nitrates, or vasodilators. Nitrates cause the vasodilation by acting directly on the smooth muscle of the vessel wall. Nitrates are of particular benefit in the management of myocardial ischemia related to heart failure because they promote vasodilation of the coronary arteries. Combination therapy. So this is hydrolizide and isosorbide dinitrate. You might see hydralazine and isosorbide mononitrate is another one. May be helpful in African American patients with heart failure who are getting optimal therapy with ACE inhibitors and beta blockers. The same benefit is not found in white patients. The combination of two drugs is associated with significant improvement in left ventricular ejection fraction and in exercise tolerance. Although the evidence of benefit is stronger in African American patients, the combination therapy may be used in patients of other races who are already on optimal therapy. Positive inotropes, so digitalis preparation, so digoxin. This increases the force of cardiac contraction. Iverbrandine or Colaner is a new category of oral drug that inhibits the sinus node and reduces heart rate. It's used for patients who have symptoms of chronic HF. They must be in sinus rhythm with a resting heart rate of at least 70 beats per minute and taking beta blockers at the highest dose tolerated. The most common side effects of this medication include symptomatic bradycardia, high BP, atrial fibrillation, and vision disturbance. And the vision disturbance is like flashes of light. Tell patients to call their healthcare provider if they experience symptoms of an irregular heart rate, feel that the heart is pounding or racing, have chest pressure, or worsened difficulty breathing. Low heart rate is a common side effect of this medication and can be serious. Patients should tell their healthcare providers if they have experienced dizziness, weakness, or fatigue. Poor adherence to a low-sodium diet and failure to take prescribed drugs is directly related to the two most common reasons for readmissions of heart failure patients to the hospital. Therefore, it's critical that you accurately assess a patient's diet and teach both the patient and caregiver about the importance of the diet. Obtain a detailed diet history. Determine not only what foods the patient eats, but also when, where, and how often the patient dines out. In addition, assess the cultural value of food. Use this information to assist the patient in making appropriate dietary choices when developing a diet plan. The National Heart, Lung, and Blood Institute provides helpful dietary guidelines for heart-healthy food preparation for people of various cultures. These are available online at the National Heart, Lung, and Blood Institute website. The edema associated with chronic heart failure is often treated by dietary restriction of sodium. So I already mentioned the DASH diet. Make sure that you are familiar with it. Because it is effective as a first-line therapy for many individuals with hypertension. This diet is now also widely used for patients with heart failure, with or without hypertension. The average American adult daily intake of sodium ranges from 7 to 15 grams. Commonly prescribed diet for a patient with heart failure is a 2-gram sodium diet. All foods high in sodium should be avoided. Fluid restrictions are not commonly ordered for a patient with mild to moderate heart failure. However, in moderate to severe and renal insufficiency, fluids are limited to less than 2 liters a day. Helping patients deal with thirst as a side effect of the drugs is important. To deal with the thirst, suggest ice chips, gum, hard candy, or ice pops. Tell patients to weigh themselves daily, as this is important for monitoring fluid status. Tell patients to weigh themselves at the same time each day. Ideally, should be before breakfast, using the same scale, wearing the same type of clothing. This helps ensure valid comparisons from day to day and helps identify early signs of fluid retention. For patients with visual limitations, suggest scales with larger numbers or an auditable response. Tell patients to call their healthcare provider if they see a weight gain of 3 pounds over 2 days or a 3 to 5 pound gain over a week. Obtain the following important health information from the patient. You're going to need to gather their past health history. So, CAD, including recent MI, is important to know. Hypertension, cardiomyopathy, valvular or congenital heart disease, diabetes, hyperlipidemia, renal disease, thyroid or lung disease, and rapid or irregular heart rate. All are very significant findings. Drugs. You want to assess the use of and compliance with cardiac drugs. Are they using any diuretics, estrogens, corticosteroids, non-steroidal inflammatory drugs, so NSAIDs, over-the-counter drugs, or herbal supplements? Carefully review the patient's current prescription and over-the-counter drugs. Assess for use of any NSAIDs as they can contribute to sodium retention. Subjective data. Obtain the following important health information related to pertinent functional health patterns. So, health perception, health management. We want to look at fatigue, depression, anxiety. Nutritional, metabolic. So, usual sodium intake, nausea, vomiting, anorexia, stomach bloating, weight gain, ankle swelling. We're also going to look at and assess their elimination patterns. So nocturia, decreased daytime urinary output, constipation, and then their activity and their exercise. Do they have difficulty breathing? Orthopnea, are they experiencing cough? Is it dry and productive? Palpitations, dizziness, or fainting? Their sleep and rest, you're going to assess the number of pillows they use for sleeping. Are they experiencing nocturnal difficulty breathing, insomnia? For their cognitive, perceptual, chest pain or heaviness, right upper quadrant pain, abdominal discomfort, behavioral changes or visual changes. And then our focus assessment findings, we want to look at the skin. Is it cool, diaphoretic skin, cyanosis or pallor, peripheral edema, which would indicate right-sided heart failure. For respiratory, we are going to look at their respiratory rate and their sound. So are we seeing that they have an increased respiratory rate? Do we hear any crackles, rhonchi, wheezes? Is there any report of frothy, blood-tinged sputum? Cardiovascular. Once again, we're going to assess for the rate, and then we're going to listen to the sound. So, are they tachycardic? Do you hear S3, S4 murmurs? Do you see any jugular vein distension? And then for our gastrointestinal, is there abdominal distension? Is there liver distension? Is there ascites present? And neurological, are they restless, confused? Do they have a decreased attention or memory? Then our diagnostic findings. So we're going to specifically look at serum electrolytes, sodium and potassium. Do they have an elevated BUN or liver function? Do they have an elevated pro-BNP or BNP? Their chest x-ray, does it demonstrate cardiomegaly? Pulmonary congestion and interstitial pulmonary edema. Their echocardiogram does it show an increased chamber size or decreased wall motion, decreased ejection fraction, or normal ejection fraction with evidence of diastolic failure? Atrial and ventricular enlargement on an ECG. And is their oxygen saturation lower or decreased? The overall goals for a patient with HF include a decrease in symptoms, shortness of breath, and so for example, shortness of breath and fatigue, we want those to decrease. A decrease in peripheral edema, an increase in exercise tolerance, and compliance with a treatment regimen, and finally, no complications related to heart failure. Those are our goals. Communication and joint decision-making among the patient, caregiver, and interprofessional team are important to selection and delivery of high-quality patient-centered care. Currently, the emphasis on aggressively identifying and treating risk factors for HF to prevent or slow the progression of the disease. For example, teach a patient with hypertension or hyperlipidemia ways to manage their blood pressure or their cholesterol with drugs, diet, and exercise. Encourage patients to obtain vaccinations against the flu and pneumonia. Patients with valvular disease should be evaluated for valve replacement procedures if they are not contributing to heart failure and symptoms. Coronary revascularization procedures should be considered in patients with CAD. The use of antidysrhythmic drugs or pacing therapy is indicated for patients with serious dysrhythmias or conduction disturbances. Many people with heart failure will experience one or more episodes of ADHF. When they do, they're usually admitted through the emergency department, stabilized there, then cared for in an ICU. Successful heart failure care depends on several important principles. Heart failure is a progressive disease, and treatment plans are established along with quality life goals. Symptom management is controlled by a patient with self-management tools. So, for example, daily weights, drug regimens, diet, and exercise plans. Next, salt and at times water may be restricted. Next, energy must be conserved. And finally, support systems are essential to the success of the entire treatment plan. Reduction of anxiety is important. Nursing function, since anxiety may increase the SNS response and further increase myocardial workload. Reducing anxiety may be facilitated by a variety of nursing interventions and use of sedatives. The Joint Commission has selected 3 core measures in the management of patients with HF to reflect standards of evidence-based care. The AHA has developed a program, Get With the Guidelines, Heart Failure, to improve adherence to standards of evidence-based care for patients hospitalized with heart failure. Together, these approaches work to ensure high-quality care for patients with heart failure. Respiratory monitoring. Monitor pulse oximetry, respiratory rate, rhythm, depth, and effort of respirations to evaluate changes in respiratory status. Auscultate breath sounds, noting areas of decreased absent ventilation and presence of adventitious sounds to detect presence of pulmonary edema. Monitor for increased restlessness, anxiety, and work of breathing. Administer supplemental oxygen or other non-invasive ventilator support, so a BiPAP, as needed to maintain adequate O2 levels. Monitor the O2 liter flow rate and position the O2 delivery device to ensure O2 is adequately delivered. Change oxygen delivery device if needed. Monitor the effectiveness of the O2 to identify hypoxemia and establish a range of O2 sat. Positioning. Position to alleviate the difficulty of breathing that these patients are experiencing is semi-Fowler's position. You're going to help improve ventilation by decreasing venous return to the heart. Hemodynamic monitoring. Perform a comprehensive assessment of peripheral circulation. So you need to check the peripheral pulses, edema, capillary refill, color, and temperature of the extremity to determine the circulatory status. Note signs and symptoms of decreased cardiac output. So look for chest pain, S3, S4, jugular vein distension to detect changes in status. Monitor fluid balance, so your eyes and nose and your daily weights, to evaluate renal perfusion. Continuously monitor cardiac rhythm to detect dysrhythmias. Administer prescribed diuretics as appropriate to treat hypervolemia. Monitor for therapeutic effect of the diuretic to assess response to the treatment. You're also going to monitor potassium levels after diuresis to detect excessive electrolyte loss. And you're going to monitor changes in peripheral edema to assess the response of treatment. Encourage alternate rest and activity periods to reduce cardiac workload and conserve energy. Provide calming activities to promote relaxation, to reduce O2 consumption, and to relieve difficulty breathing and fatigue. Monitor patients' oxygen response to self-care or nursing activities to determine the level of activity that can be performed. Collaborate with occupational and or physical therapists to plan and monitor activity and exercise programs. Instruct the patient and caregivers on activity restriction and progression to allay fears and anxiety. Establish a supportive relationship with a patient and caregiver to promote adherence to the treatment plan. Evaluate and encourage the use of support systems. Teach the patient and caregiver techniques of self-care that will minimize O2 consumption. Inform the patient of the purpose for and the benefits of the prescribed activity and exercise. So, heart failure is a chronic illness. When a patient is diagnosed with heart failure, care should be focusing on slowing the progression of the disease. Your important nursing responsibilities include teaching the patient about the physiologic changes that have occurred, assisting the patient to adapt to both the physiologic and the psychologic changes, and include the patient and caregiver in the overall care plan. Review the signs and symptoms of heart exacerbations with the patient and caregiver. Give them clear action plan to follow should symptoms occur. Early detection of worsening heart failure may help to prevent an acute episode requiring hospitalization. Patients with heart failure are at risk for anxiety and depression. Emphasize to the patient that it is possible to live productively with this chronic illness. Patients with heart failure usually need to take drugs for the rest of their lives. This often becomes difficult because the patient may be asymptomatic when heart failure is under control. You must stress that the disease is chronic and that the drugs must be continued to keep the heart failure under control. Teach the patient the expected actions of the ordered drugs and the signs of drug toxicity. Also, teach the patient and caregiver how to take a heart rate. The heart rate should always be taken for 1 full minute. A heart rate less than 50 beats a minute may be a contraindication to taking digoxin or a beta blocker, unless specified otherwise by the healthcare provider. However, the absence of symptoms, a heart rate less than 50 beats a minute may be acceptable. Include clear information about when a drug, especially digoxin and beta blockers, should be held and a healthcare provider called. Teach the patient the symptoms of hypokalemia and hyperkalemia, if diuretics that deplete or spare potassium are ordered. Weakness, fatigue, constipation, and muscle cramping may occur, but often there are no physical signs of hypo or hyperkalemia. Frequently, the patient who takes thiazide or loop diuretics is given supplemental potassium. It may also be appropriate to teach patients home BP monitoring, especially those with hypertension. Consult the written diet plan and list of permitted and restricted foods. Examine labels to determine sodium content. Also examine the labels of over-the-counter drugs such as laxatives, cough medicines, and antacids for sodium content. Avoid using salt when preparing foods or adding salt to foods. Weigh yourself at the same time each day, preferably in the morning, using the same scale, wearing the same clothes. Eat smaller, more frequent meals. These are all part of your patient teaching. For activity and rest, we're going to tell them to increase walking and other activities gradually, provided they do not cause fatigue or difficulty breathing. Consider a cardiac rehab program. Avoid extremes of heat and cold. Rest. The physical therapist, occupational therapist, or you can instruct the patient in energy-conserving and energy-efficient behaviors after an evaluation of daily activities has been done. For example, once you understand the patient's daily routine, suggestions can be made to simplify work or modify an activity. Exercise training or cardiac rehab improves symptoms of chronic HF, but is often underprescribed. Exercise for patients with heart failure can be found to be safe and improve the overall sense of well-being. It has also been correlated with mortality reduction. We're also going to want them to increase their walking or other activities gradually, provided they do not cause them any fatigue or difficulty breathing. Avoid extremes of heat and cold. Frequently, the patient needs a prescription for rest after an activity. Many hard-driving persons need the permission to not feel lazy. Avoid emotional upsets. Verbalize any concerns, fears, feelings of depression, etc. to the healthcare provider. Ongoing monitoring. So, know the signs and symptoms of worsening heart failure. Remember the acronym FACES: fatigue, limitation of activities, chest congestion or cough, edema, shortness of breath. Recall the symptoms experienced when illness began. Reappearance of previous symptoms may indicate a reoccurrence. You want to report immediately to a healthcare provider if any of the following. You have a weight gain of 3 pounds in 2 days, 3 to 5 pounds in a week, difficulty breathing, especially with exertion or when you're laying flat, waking up breathless at night, frequent dry hacking cough, especially when laying down, fatigue or weakness, swelling of ankles, feet, or abdomen, swelling of the face or difficulty breathing, especially if you're taking ACE inhibitors, nausea with abdominal swelling, pain, and tenderness, dizziness or fainting. Follow up with your healthcare provider on a regular basis. Consider joining a local group with your family members and or caregivers. Then for health promotion, we're going to also encourage an annual flu vaccination, obtain a pneumonia vaccination or revaccination after 5 years, and develop a plan to reduce risk factors. So once again, we want to encourage the blood pressure control, tell them to quit smoking if they smoke, and weight reduction. Managing heart failure patients out of the hospital is a priority. Effective home health care can prevent or limit future hospitalizations by providing ongoing assessments. Many agencies offer specialized programs dedicated to managing heart failure patients at home. For example, these programs may include the use of telehealth monitoring technology, so an electronic scale, a blood pressure cuff, or a pulse ox, to collect physiologic data. The technology may also be able to audibly ask the patient questions like, "Are you short of breath today?" Results are transmitted telephonically or by a computer to the home care agency. Once received, the data is reviewed. Based on the findings, the patient may be called to further assess the situation or visit may be scheduled. Home health nurses frequently work with protocols set up with the patient's healthcare team. The protocols enable you and the patient to identify problems such as an increase in weight or difficulty breathing as evidence of worsening heart failure. Interventions can be started to prevent hospitalization. They may include changing drugs and restricting fluids. Home health nursing care of heart failure patients is vital in reducing the number of hospitalizations, increasing functional capacity, and increasing the quality of life. This is just a picture of a home care visit. Heart transplantation is the transfer of a healthy donor heart to a patient with a diseased heart. Surgery is used to treat a variety of terminal and end-stage heart conditions. Retransplantation, a second or a third heart transplant, is also done. In the United States, approximately 3,000 patients are listed for heart transplants. However, on average, only 2,000 hearts become available. The 1-year transplant survival rate is 85 to 90%, whereas the 3-year survival rate is approximately 75%. A careful selection process ensures that the hearts are distributed fairly and to those who will benefit the most from the donor heart. The United Network for Organ Sharing is in charge of a system that gives organs fairly to people. Once a person meets the criteria for the heart transplant, a complete physical examination and diagnostic workup are done. In addition, the patient and caregiver undergo a comprehensive psychologic evaluation. This includes assessing coping skills, support systems, and commitment to follow the rigorous regimen that is essential to a successful transplantation. Donor and recipient matches is based on body and heart size and an immunologic evaluation. The assessment includes ABO blood type, antibody screen, panel reactive antibody level, and human leukocyte antigen typing. Once a person's accepted as a transplant candidate, he or she is placed on a transplant list. Patients may wait at home and receive ongoing medical care if their condition is stable. If their condition is not stable, they may require hospitalization for more intensive therapy. Therapy may include implantation of a bridge device, to assist the heart while awaiting a transplant. Unfortunately, the overall waiting period for a new heart is long. Many patients die while waiting for a transplant. Several devices are available as a bridge to transplantation, but only 2 have received FDA approval for heart recovery after life-threatening cardiac event. The surgical procedure actually involves multiple surgeries. First, the donor heart is retrieved. The donor is usually someone who has suffered irreversible brain injury. Most donor hearts are obtained at sites distant from the institution performing the transplant. A team of physicians, nurses, and technicians go to the hospital of the donor to remove donated organs once the brain death of the donor has been determined. Often the donor heart is flown to the recipient hospital. Second, the donor heart is implanted into the recipient. 2 different approaches are used in this surgery. In the biatrial approach, the recipient's damaged heart is removed at the mid-atrial level, and the donor heart is connected at the left atrium, pulmonary artery, aorta, and right atrium. In the bicaval approach, the right atrium of the recipient's heart is preserved, and then the donor heart is connected. Cardiopulmonary bypass is needed during the surgical procedure to maintain oxygen and perfusion vital to the organs. Human heart that's being prepared for transplant for a patient. So post-transplant monitoring. A variety of complications can occur after a transplant, including risk for SCD. Acute rejection is an immediate post-transplant complication, and immunosuppressive therapy is key in post-transplant management. In the first year after transplantation, the major causes of death are acute rejection and infection. Later on, malignancy, especially lymphoma, and cardiac vasculopathy, so that's accelerated CAD, are major causes of death. Most immunosuppressive regimens include corticosteroids, calcineurin inhibitors, and antiproliferative drugs. So, you guys are familiar with corticosteroids. So the calcineurin inhibitors include, the one I see the most probably is tacrolimus, or Prograf is another name for it. And then the antiproliferative drugs, it's usually just the one, the mycophenolate, Mofetil, or Cellcept. You will see these on people's drug lists, and if you see Prograf or Cellcept, you know that they've had a transplant of some sort, because they're used in other transplants as well, like a kidney transplant or a liver transplant. Because of the use of immunosuppression therapy, infection is a primary complication after the transplant surgery. On a long-term basis, immunosuppressive therapy increases the risk for cancer. To detect rejection, an EMB is obtained on a weekly basis for the first month, monthly after that for the next 6 months, and then yearly after that. In this procedure, a catheter is inserted into the jugular vein and moved into the right ventricle. The catheter uses a biotome, a device with 2 small cups that can be closed to remove small samples of the heart muscle. In the EMB, a catheter is being put into the jugular vein and then it goes down into the right ventricle. I just said this. And then they get a small sample of the heart muscle. So nursing care for a transplant includes nursing management through the post-transplant period, focuses on promoting patient adaptation to transplant process, monitoring cardiac function, managing lifestyle changes, and providing ongoing teaching to the patient and the caregiver.